Hey there, this is Dr. Evan Osar, developer of the Integrative Movement System and author of the Corrective Exercise Solutions to Common Hip and Shoulder Dysfunction. Welcome to video 2 of this 3-part series, Integrative Movement Insider, where we're discussing working with a client that has a diagnosis of either labral tear and or femoral acetabular impingement, or FAI. Recall from video 1, so make sure you check out that video before watching this video, because this information is important and builds upon the information from video 1. That we discussed one of the most common things we see clinically. And again, I've evaluated thousands of hips from 13-year-old girls that have had femoral acetabular impingement and labral tears to 70-year-old individuals that are going for hip replacement. And the common thing that we see in all these individuals, and actually the research actually shows the same exact findings, is we generally see a change in position of the femoral head, and we start to see changes in the musculature around the hip. What we see most frequently is the femoral head moves too far forward and or is too far compressed into the joint, so that the acetabular. So the ball is too compressed and usually too far forward and superior in the acetabular. So why do so many of our clients have that position? Because too many of our clients have been taught or have been reflexively gotten into these positions where they overgrip the lateral hips, so the lateral glute fibers, and the posterior hip fibers and deep rotators. And that will generally overcompress the hip and drive the femoral head forward and up into the acetabular. Over time, this creates wear and tear on the cartilage surfaces of the acetabular and femoral head. It leads to bony changes, the things that we call femoral acetabular impingement. And it also relates to what we're seeing more frequently. And in younger patients, like I said, 13-year-old girls, I'm already seeing labral tears in that patient population. The great news is we've been successful in helping many individuals not have to have surgery and recuperate from labral surgery after if they've needed labral surgery. Femoral acetabular impingement is a more challenging condition because now you have and are dealing with bony changes around the femoral head and or the acetabulum itself. However, the strategy we use with each of this client population is exactly the same. What we want to do is allow the individual to develop a strategy that allows the femoral head to glide further back into the acetabulum, or the ball to glide further back in the socket, and then to use the musculature around the hip complex to better control the position so they're not creating that overcompression and or that superior and or anterior glide. So one of the patterns we use most frequently is the bench stretch. So you've done your evaluation already, you've done your assessment to determine your client's range of motion, where they're having restrictions, myofascial restrictions. You'll do your soft tissue work, your manual therapy, your trigger point work, whatever you want to do around the hip joint to release that myofascial gripping. Now we're going to teach the client how to mobilize their hip safely and effectively, because so many of our clients are actually creating problems or perpetuating problems by the way they're stretching their hip. Let me show you a perfect example. Many of our clients are doing exercises or stretches like that pigeon stretch, and I'll show you on the bench just so you can see it. And that's where the client comes into this position here, and they sit forward and they just kind of hang out. So most clients will feel a tremendous stretch in their hip back here. However, the challenge with this position is most clients are stretching themselves right into their dysfunction, meaning they're overstretching their lumbar spine. And you can see here, I have a lot of stretch in my lumbar spine before I ever get a stretch in my posterior hip. The other challenge with this position is most clients aren't actually moving the pelvis appropriately over top their femoral head. They're not moving the socket over top the ball of the hip joint appropriately, meaning they stay in a posterior pelvic tilt and they're just overstretching their back. So we're going to make a simple modification to this position. For most of our clients that have labral and or hip issues, we're not going to put them on the floor because they don't have the range of motion to stretch on the floor or mobilize their hip while they're on the floor. So they need to be elevated on a surface so that they can move the pelvis over top the femoral head. And here's what I mean. So I'm going to align my femur up with the bench, because I know I don't have the range of motion to be on the floor and stretch my posterior hip appropriately without overstretching my low back. Next, I'm going to place my hands upon my pelvis and rotate that pelvis towards my leg. So most of our clients will be over here and then they're stretching like this. What we want to do is get them to rotate towards their leg that's on the bench. So therefore you're rotating the pelvis over top of the femoral head. Now you're going to move anteriorly and rotate that and
pelvis anteriorly until now I'm getting a stretch right here, and now I'm respecting the alignment of my thoracopelvic cylinder and my lumbar spine. So therefore the stretch is very specific to my hip, and I'm going to make it very active because ultimately I need these muscles to rotate and move that pelvis when I'm in the upright position and or during functional activity. If you're just hanging out in stretches, it doesn't teach muscles how to control that position. It just teaches them how to mobilize and be long. We want to teach them how to be active, so we're going to rotate towards that forward leg and then hinge forward. So now the stretch and mobilization happens right here in my deep posterior hip. So now I have a very active stretch. I'm staying long through my spine because ultimately this is what I need to have happen when I walk, when I run, when I do all my functional activities and sport. So very effective way. We're gonna hold for 10 to 15 seconds and then slowly come out of that position. And then again, rotate towards, hinge forward, keeping the spine neutral, staying long until I feel that stretch here. Now, a lot of our clients that have femoral acetabular impingement, they will be impinging themselves in this position. So we have to modify that just a little bit for them. So let me turn and face the camera. So with those clients, what we're going to do is we're going to allow them to cheat over just a little tiny bit. So here's a pelvis position. Because that position, they're still going to bring the pelvis up and over the femoral head. So that way they're still getting that stretch back here, but they're not moving into that impingement position, which is ultimately here. So if your client has an active and uncomfortable labrum and or femoral acetabular impingement, you're going to actually move their pelvis slightly away from the forward leg, but still get that hip hinged position, so they're still able to move and actively move that pelvis over top the femoral head. And that's one of the most important patterns we use initially with our clients to help them mobilize the hip and actively start to move that pelvis over top the femoral head to mobilize the posterior hip and also use those muscles in a more active fashion. In the next video, I'm going to show you how to take that into the upright position and single leg or split stance position, so that way you start to teach them how to actively move through that range of motion that they can control, so they have better range of motion and better functional control around the hip joint. This is Dr. Evan Osar with Integrative Movement Insider. Hope you enjoyed this video. We'll catch you in video 3 next time. Take care.